Okay, I believe we are live. Welcome on behalf of the North Texas County Medical Society Coalition, a group of 11,000 physicians represented across North Texas in Tarrant, Denton, Collin, Grayson, Fannin, and Dallas counties. I'm joined tonight by two colleagues and two friends to discuss the science behind the COVID-19 vaccine. Hopefully explore some of the realities and address some of the myths about this. I want to allow my two colleagues to introduce themselves. I'm joined tonight by Dr. Bryan Johnson and Dr. Gregorio Gomez. Dr. Johnson.
Hi, Dr. Bryan Johnson. I am a practicing internist in North Dallas and Frisco, Texas.
Hi, everyone. My name is Greg Gomez. I'm an associate professor of immunology at the University of Houston College of Medicine.
Great. And again, I'm Mark Casanova, the immediate past president of the Dallas County Medical Society. Happy to pass the baton to my colleague at this point. Doctors Johnson and Gomez, I was able to actually partake in the Pfizer study. This was back in September, and had a real life experience with the COVID-19 vaccine that after unblinding, realized I got the real deal. And it's certainly heartening to see so many individuals now getting the vaccine and pursuing that goal of, through vaccination, bringing the COVID-19 vaccine experience to an end. So as many individuals look forward to receiving the vaccine, or even if they have doubts and they need more information about it, we want to look to the two of you and provide us some guidance. We'll start with Dr. Gomez. Can you briefly explain what an mRNA vaccine is and how it works?
Yeah, sure. So an mRNA vaccine is basically composed of small strands of viral RNA. And that viral RNA contains all the information needed to make a very specific protein. And so this mRNA will be taken up by our cells, and our cells will make that viral protein. And in turn, our immune cells will recognize that viral protein and make antibodies against it, so that when we're infected naturally with the virus, we have the antibodies to protect us and the cells to make more antibodies that can protect us as well. One thing that we should be aware of that's important to know is that this mRNA does not incorporate into our DNA. And so there's no chance for any sort of mutation or any cause for concern in that regard.
So as I hear you explain that, Dr. Gomez, it kind of sounds like basically what we're delivering in this messenger RNA vaccine from both Pfizer and Moderna is sort of like a blueprint, if you will, a template that's presented to our body, and it merely takes this template and reproduces this protein that our body can then recognize.
Yeah, that's absolutely correct. I mean, the RNA contains, like I said, the information needed to make a viral protein. And that is all that our cells need to produce a viral protein. And that protein will act then as sort of a message to our immune cells to create antibodies that are going to stay in our body and protect us against natural infection.
And I also heard you say that this in no way incorporates into our own DNA. It doesn't get into our nucleus. So I guess my hopes for growing a few more inches and having a fuller head of hair are probably not going to happen. Is that what you're saying?
That's right. You don't have to worry about any negative effects, and unfortunately, you won't get any
nor any of those potentially positive ones either, I guess.
That's right. Other than being protected from SARS-CoV-2.
Hey, I will take 5'5"3/4" and protection from SARS-CoV-2 any day of the week. Absolutely. Dr. Johnson, what are the most common reasons that your patients, you're a busy internist, you see a whole lot of patients here in North Texas. What are some of the common reasons your patients may be reluctant to get the vaccine, and what do you tell them to reassure them that it's safe and effective?
There's a lot of misconception about the virus, because many people have read on it, but the sources that are out there are sometimes leading them to believe that the vaccine may have negative effects that just aren't true. And so much of my time is spent dispelling many of the myths that are out there. as you and Greg were talking about, one of the things that people are very concerned about is whether or not there are long-term effects of injecting or receiving messenger RNA. And they've read on the internet that would incorporate into their DNA and then lead to some consequences down the road. And as Dr. Gomez said, that's just not the case. So much of my time is spent dispelling many of the myths. They also in addition to their safety, they want to make sure that it's effective, and its effectiveness has been shown in the rigorous studies that have been done thus far, that the medication is extremely effective as well as very safe. And so those are many of the things that we are dealing with. One of the other things that I think is very interesting that I didn't expect to hear, and that is that the community has read a lot about this, and they have some concerns about whether or not receiving the vaccine will lead to any future test resulting in a positive test because of this. And so the answer to that is that no, it will not lead to them having a positive test. If we're ever testing for antibodies like we did in the early stages of when we were testing for the virus, that test will be positive, but that is not, it does not mean that they are infected or that that they are contagious. So, but those are some of the myths that we're seeing in the community.
Thanks, Dr. Johnson. And it sounds like a good chunk of your day as of late, as has been for a lot of us, is one of those more historical roles of the physician to be the teacher.
Mm-hmm.
Something that we sometimes lose sight of, but a very sacred role that we have the privilege of partaking in. And also the fact that, as you pointed out, it's important for folks to understand that receiving this vaccine will not give a false positive test for coronavirus, for COVID-19. I think I've also heard, reports that it's also equally important to make sure you stay protected, certainly between shot 1 and 2,
mm-hmm.
and even for a period of time thereafter before pure or true immunity kicks in. Now, speaking of immunity kicking in, Dr. Gomez, how many people in our society, in our population, need to receive the vaccine for us as a group, as a society, be protected?
Sure, that's a great question. And unfortunately, there's no hard number for what we call herd immunity. But we can estimate that at least 75 to 85% of the population would have to be immunized in order for us to feel the effects of herd immunity. But again, there's no hard number that we can look at to say this exact number of people have to be immunized. We can say generally 75 to 85%.
Dr. Gomez, you used a key phrase. You said herd immunity. And some of us have heard that phrase recently bantered about in the news media and the like. If I recall from medical school and my history of medicine classes, herd immunity really applies to the notion of vaccination, to providing protection for enough individuals that those other members of society, otherwise referred to as the herd, are still protected, because a virus can't gain a foothold. It can't transmit from person A to B to C. So therefore, D is protected despite the fact that they haven't received the vaccine. Is that a correct utilization of the term herd immunity? It really applies to immunizations?
Yeah, that's exactly correct. I mean, if you have enough people that are vaccinated, essentially we're stopping the vaccine, the virus in its tracks, because it's likely to infect someone who's been already vaccinated. And so it essentially will kill the virus in its tracks and won't be able to infect someone who might not be vaccinated. So yes, you're correct.
Well, something we can certainly look forward to. But until we get there, and Dr. Johnson, this actually dovetails off what we had just discussed a little bit ago. How long after getting the vaccine are we protected? Do we have information about that? And why 2 shots?
We believe that it is immunity is developed after 1 month. So the two most common vaccines that we're using right now are the vaccine that has been produced by Pfizer, and the other one is a company called Moderna. And they both, after the first shot, the Pfizer vaccine, if I remember correctly, is around 60% develop immunity after between the first and second dose. And the Moderna vaccine, I believe, is 80% prior to the second dose. Because of that, that leaves that, if I didn't mention it before, there are two shots that are necessary for the vaccine. The Pfizer vaccine requires the second shot to be administered somewhere around a 3-week, after 3 weeks after getting the initial injection. And the Moderna vaccine is 1 month, 4 weeks. And so that period of time between the first administered injection and the second injection, there still is a possibility that an individual can become infected during that time. You really haven't managed to acquire the type of immunity that's necessary to fend off an infection. That's why the second dose, considered as it's called a booster, is necessary to fulfill that, to beef up the body's immune system so that you are effectively able to fend off the virus if you were ever to come in contact with it.
So, if I understand you correctly, Dr. Johnson, the take-home message is vaccination is important. We need to reach herd immunity, but one shot in the shoulder doesn't quite do it. It takes two, and then it also takes tincture of time. So I'm guessing in that time frame, we'd want folks to still adhere to those 3 pandemic commandments: washing your hands, watching your distance, and wearing your mask, because it seems like either they may be at risk, or as Dr. Gomez mentioned about the potential for transmitting the virus, it could still land on them, get a foothold, and then pass it to another individual.
Exactly.
Okay. So, Dr. Gomez, one of the things that we hear a lot about, and I think we understand why we hear this, is nervousness about the vaccine, but more specifically, the speed with which these two vaccines were developed, not to mention the speed with which other vaccines are being developed. And the concern were shortcuts taken. How is this possible? How were we able to get here so fast? Not that we're looking a gift horse in the mouth, but what do you tell people about the speed with which these were developed and what safety steps were taken?
And so the concern, of course, is understandable, but I hope people understand that the technology that was used to develop these vaccines has been in place for a long time. And so we just happen to have them available for developing these vaccines. And so we didn't have to develop new technology, it was already in place. The other thing to remember or recognize is that traditional vaccines generally involve growing the virus, and that's a very long time. In contrast to that, we can generate in the lab mRNA very rapidly, real fast. And so we didn't have to develop new technology, and it's much faster to generate mRNA in the lab than it is to grow intact virus. So those two things are why it was so fast. And there were no shortcuts taken, just to be very clear about that. Absolutely no shortcuts were taken in developing these vaccines.
So yes, it was fast. I think probably fast out of necessity, but it sounds like we had the framework in place, regrettably waiting for a mutated virus to come down the pike and be put to use.
That's right. Thankfully, we had the technology in place and everything was ready for the vaccines to be developed. But again, I want to emphasize to the community that there were no shortcuts taken. All the tests were done, and again, no shortcuts were taken whatsoever.
So, Dr. Gomez, we've spent a fair amount of our time so far discussing these two vaccines, both very similar. Is it safe to say they're kind of like Coke and Pepsi, both colas, right?
Sure.
But we're in Texas, so I don't want to throw in Dr. Pepper in there.
So they're they're both mRNA vaccines, and they both have 95% efficacy. So they work identically. They work equally well.
Yeah. So what can we expect? Because we've heard reports that these two were not the only viable candidates. And is it safe to expect that we're going to have some more vaccines coming down the pike? And what might that look like?
Absolutely. I mean, there's several vaccines that are undergoing clinical trials right now. More recently, for example, Johnson & Johnson has reported a vaccine that they're working on that importantly could require only a single dose. And this is a more traditional vaccine. It's still not available yet, but yes, there's other vaccines that are being developed. So I would not be surprised if there were other COVID vaccines available sooner than later.
When I hear you say that, what it brings to mind is the potential that in a number of the months ahead, possibly not too many months ahead, not only will we have an increased amount of our current two vaccines, but we may actually also have other vaccines in the field and ready to distribute into folks' shoulders.
I agree 100%. There will be other vaccines available. I have no doubt.
I think that's heartening news. And as as I look at our current situation and the vaccine rollout, and all one needs to do is watch the evening news and understand, or the morning news and understand, there's a lot of emotional energy behind it, right? Everything from hope and optimism, and we're excited, to gosh, some folks are really nervous and they're scared. So how do we take care of each other and allay those fears? To now there's frustration and there's angst of where is mine and why can't I get it? Dr. Johnson and I had visited with this a little bit and talked about it. To roll out this endeavor on this scale is quite an undertaking. We saw the same challenges a number of years ago when we faced H1N1, where that initiation was bottlenecked by the supply. But as the supply came along, it increased. I think it's also led, as folks observe the region. Here we are discussing amongst the North Texas region, but there may be Facebook viewers who are joining us from other areas of the state, other areas of the nation. And what you see and what is a reality is that certain communities, certain entities, certain hospitals, certain towns, certain cities seem to be at various places in their distribution in terms of working through the hierarchy of distribution. Healthcare workers, nursing home residents, the most vulnerable, the most at risk, then getting to our population of patients who we do know have some of the greatest impact in terms of the potential impact for disease and morbidity, degree of illness. Dr. Johnson, what are your thoughts about how this is unfolding and sort of that textbook, here's an ideal scenario, and here's how the pragmatic real life rollout is?
That is probably one of the biggest, probably will be one of the biggest challenges that we're going to face going forward. And that is, how do we approach some degree of equity amongst society? And I think you're right. I think that the current recommendations are sound. They make sense. But the problem is what we've seen time and time again, and that is getting the shots into people's arms. And that is the bottlenecks that you describe that we ran into with previous epidemics. Now we're running into that same problem, and it's unfortunate. I think that we'll resolve that. I think that we will, once we get enough supply, I think that we'll be able to have it distributed so that you could go to any drugstore, your physician's office. You'll be able to go anywhere and get the vaccine. But I think that those challenges are there, and I think that the biggest problem that I see right now is that people don't know where to go. They're not really sure of what category they fall into, and I think that some of that is faults of the states and not being able to communicate the message as to the categories that are recommended at the federal level and how they want to implement that in each and every state. So I have people who are in the category of 1C. So the categories are basically this. Category 1A will be your healthcare providers and residents of nursing homes. That's your 1A category. The 1B category falls into, those are going to be your frontline essential workers. They're going to be teachers, firemen, police officers, and some manufacturing groups. You're also going to find that the 1Bs will also be those that are 75 and older fall into 1B. And then the 1C category, it will be individuals who are 65 to 74. They'll fall into the 1C category. And and some of them have to have comorbid illnesses. Now, also, you can get 16 and 65, somewhere in there, if you have comorbid illnesses that would put you at risk. Everyone else isn't really a 1C, and they really haven't defined that. You can call it a 2 or what we're going to do. And I think that those are the problems where the people that are in those groups don't know when they will get theirs. And so what we're trying to tell people is it's a moving target every day. And once we are able to distribute the vaccine in the community to all areas, I think, and when I say all areas, I mean your doctor's offices, your local pharmacies, and areas like that, and increase the surface area. Basically, if you think about that, more people will begin to have access, and then we can see those numbers rise a lot faster so that we can achieve herd immunity by late spring, early summer. But there are going to be several challenges in doing that, and that's it's going to take a while. And I hope that people who are not in any of those categories can receive the vaccine maybe by late March, maybe by April, if we're lucky, if we do this right. It can be done, but there's just got to be more coordination and better logistics on how we can get this vaccine out to people and for them to receive the vaccine.
So that was actually my next question, and I want to expand on the criteria a little bit. The next question was, okay, you're younger than 75 and 65, or maybe you're 65, but you're generally healthy. And what's the time frame we're looking at for otherwise healthy individuals, not critical essential workers? When might we expect them to begin getting vaccines, understanding that population across the U.S. is measured in the order of millions of individuals, and your idea is possibly if we can get through our 1B, 1C, that late spring, early summer range. I've also heard some estimates that when you then factor in getting those category 2 patients or 1C patients immunized, that probably will take us through the summer into the fall. What's unknown, and Dr. Gomez alluded to this as well, how will that time frame be affected by not only an increased supply of the existing 2 vaccines, but then the addition of additional vaccines? So I think many of us are working on estimations. I mean, we can only know what we have right now and then make that prediction, but we know there's a good chance that that time frame could be sped up or abbreviated.
Exactly.
Yeah. You also mentioned that, I think in some of the initial guidelines put forth at a federal level and even other areas, they did kind of differentiate those individuals who were over 75 as being sort of the true, 1B, if you will. And then 1C was originally looked at as being 65 and older, but with certain medical conditions. I believe the list includes obesity, underlying lung disease, diabetes, chronic kidney disease. So if individuals' kidneys aren't functioning to the full capability, heart disease, asthma, or other pulmonary diseases. If folks have a suppressed immune system, like from cancer or medications that are intentionally suppressing their immune system, sickle cell disease, just to name some of the top conditions that we know have led to increased severity of illness for individuals. But we are operating at regional county levels at the behest of our state Department of Health and Human Services, and we know that the governor has said, listen, we really want to focus on 1Bs as defined as 65 and older.
Mm-hmm.
But what I hear you say is yes, that's the direction from the governor, that's the direction from the state health department. Our county health departments will follow suit and follow our marching orders. But remember, we also want to make sure that in as much prioritization as we can give those 75 and older, especially those 75 and older have those medical conditions, we want to focus on that.
Exactly.
Is that kind of a safe way to look at it?
I think so. I agree.
Dr. John, you also made a really key phrase, and this is the quintessential cornerstone of vaccination, is equity,
Mm-hmm.
right? Fairness. And as we've mentioned, those individuals who are hit harder and have been hit harder by COVID-19, those with underlying medical conditions, but we've also seen a differentiation based on ethnicity, as we have for many other medical conditions, what we refer to as social determinants of health, those factors in various communities that can lead to increased severity of illness, increased frequency of illness. And in the case of COVID-19, increased likelihood of hospitalization, ICU admission, and regrettably death. And the two groups that have borne the greatest weight of that have been our African-American and Hispanic populations, our brothers and sisters. And I know that when I sit through a lecture or hear a discussion about social determinants of health, on one level, I'm energized with the knowledge that we need to do better. We can do better for each one of us. And then I'm also a little disheartened because some of these solutions are things like reformatting public education and addressing a grocery store in a food desert, things that take many years and some things that may take a generation or two. But I look at this COVID-19 situation and the vaccine in particular, and I think this is an opportunity where we can address this in a much quicker way. We don't have to wait decades. We don't have to wait for a generation. We don't have to wait for something to change. We can change this now. What are your thoughts about that?
I agree. I think we can, and I think that there is a great deal of inequity that we see as far as the communities that are currently suffering from the illness. You see it in the areas around El Paso. You see it in inner cities, and there is a discrepancy as far as even the care that those individuals are receiving. I do think that this presents itself as one of the first opportunities where we can see, if we do this correctly, we can see equity distributed in underserved areas that normally you don't see. But I think that it comes from having a sensitivity and an understanding that these areas are in fact in need, and that only by making a concerted effort to help to save these communities do we realize that we all benefit from that. Because if we allow these areas to suffer and lag, it just continues to perpetuate the illness and other problems that will result from this. And so we have to see that by paying the dividend, by paying it now, gives us there are dividends that we don't even understand and can't even conceive now, that we'll see in the future by providing this equity in the areas that are suffering significantly.
So maybe the opportunity to pull a glimmer of hope out of darkness. Okay. Dr. Gomez, do we have any idea of how long immunity will last from these vaccines? And I'm talking about once, of course, we get our 2-shot series, for example, and immunity is set in. Is this going to be a situation, do we understand if we know we'll need a booster every year? Where are we at with our understanding?
Yeah, so this is one of the unknowns right now, unfortunately. It's too early to tell, I think, how long exactly protection from these vaccines is going to last. I mean, it could be long-lasting protection, or it could be possible that we'll have to have a booster every year. It's right now, because the vaccine is just being rolled out, and people are just now taking it. I think that it's a little too early to tell exactly how long that immunity is going to last.
Yeah, Dr. Gomez, that's the answer that many of us in medicine, in research, and public health have had to become comfortable with acknowledging is, I don't know.
That's right.
But we got to be honest.
That's right.
Yeah. Dr. Johnson, we mentioned a little bit ago about some of the underlying health factors that could give an increased risk of COVID-19 complications. Are there factors that some individuals may have, health conditions that would prohibit them or would discourage them from getting the vaccine?
One of the major ones that we're concerned about are any individuals who have what are called anaphylactic reactions to either their initial dose or certain chemicals that we find that are commonly used in many things that we use commonly on a daily basis. So if anaphylaxis is a type of it's an immune response to something, we often think of it like with bee stings or some people have allergies to nuts and things like that, where it causes a constriction of the airway and it can lead to death if not treated appropriately and quickly. And so those are serious things that you have to be concerned about when you're administering when you're taking medications, and especially when you're administering a vaccine. And so any individual who develops that, and we don't see it very often, but in an individual who develops a type of reaction like that, we would encourage them not to receive the second dose of that vaccine, nor would we recommend, in the case of the messenger RNA, because we can only work with what we have. And so it would be not advised for those individuals to receive the Moderna vaccine either. Now, if the Johnson & Johnson vaccine comes online, then that may be a little different and that may provide them an outlet, but it's unknown right now. Other things are if you're allergic to polyethylene glycol, commonly found in disinfectants, hand wipes, sanitizers, and things like that. If you have not a skin reaction, talk to your physician about that, and you can decide on which way to go. But we're talking about the very severe types of reaction that will require an emergency room visit, or for those who have a history of these types of reactions and they have what's called an EpiPen. It's something that they can administer to themselves if in the case they ever have a bee sting, for example. Those individuals should not use, if they have reactions like that, they probably shouldn't use anything with polyethylene glycol. Would be something we wouldn't advise. Also, there's another product that's found in shampoos, facial creams. Polysorbate is another ingredient that is found in both vaccines that is it stabilizes the vaccine, to my knowledge, and can be considered something that we would recommend that they not receive the vaccine.
So you actually you actually provided the second most common answer we've been providing over the last 9 months. The first is, I simply don't know, but we're going to get back to you with more information. And the second is, make sure you ask your doctor. Dr. Gomez, in my read of the data and in analyzing it, am I correct in the fact that the incidence of anaphylaxis to date seen, or these severe allergic reactions seen to the COVID vaccine, is in fact quite a bit lower than what we see from a lot of antibiotics that we delve out on a daily basis?
That's very true. That's very true. I think that the anaphylaxis the occurrence is extremely low.
Okay.
And you're right. It has surprised us that we are seeing such low cases, and we're not seeing anything really. And I think that that's because of the vector that we're using.
Yeah, we'll take positive surprises whenever we can get them. Dr. Gomez, we kind of touched on this earlier, and I think you actually provided some of us some insight into it, but are either one of these two current vaccines better than the other? Is there a meaningful difference between the two? Is there any validity in requesting one or the other?
No, they both are equally effective. And the recommendation is take the first one that becomes available to you. They both use the same strategy, mRNA, and they both have exhibited about 95% efficiency or efficacy. So whichever one becomes available first would be the first one that you should take.
But I understand you still want to stick with that one. So, and also probably stick with the same location that's administering it, because the state is using a computer-based program called mTrack to ensure that that vaccine is tracked to you, Joe Smith, to ensure that you got Pfizer dosage 1, time point X, Pfizer dosage 2, time point Y. So I think that's an important reminder. Dr. Johnson, Facebook and social media can be fun when you see cat videos or dog videos, but it can also be a source of a lot of confusion, quite frankly. How do we separate out what's fact, what's fiction, and what's just a bunch of hullabaloo?
That's hard. I mean, it's the the bane of my existence. I think that the best thing to do is, and with having a relationship with my patients, they use me as that source, and I think that I think what I do is I will lead them to certain areas to go to for information. I think that for healthcare providers, I think that the World Health Organization sites are good. I think the CDC sites are very good. And I even send my patients there. I think that I found that for those who are not professionals, I think that a good site other than the Center for Disease Control or CDC is the Johns Hopkins coronavirus resource center or site, whatever that is. And I think that that is a very, very good. I'm really impressed in how they break that down so that it's understood, and it can be understood by people of various degrees of understanding of their health. And it's a really valuable resource, and they can break it down as to if vaccines are available in your area, how many. It's really detailed and good information. So I send a lot of people to those sites and tell them to stay away from everything else. And before they decide to do anything, call me, and we'll go from there.
There you go. Answer number 2, ask your doctor. Dr. Gomez, speaking of asking your doctor, what would our answer be if a patient called us and said, what are the common side effects with the COVID-19 vaccine? I certainly know what I experienced, but I'm curious what we should be telling folks.
So I think that the common side effects are, headaches, a little bit of muscle soreness in the arm that you take it, maybe some, mild cold-like symptoms that you will probably experience for a day or two. I think those are the major symptoms or side effects that you'll have after taking the vaccine.
Yeah, I would agree. That was certainly my experience. I thought for a little bit that muscle soreness were those bones stretching and those 2 inches of extra height, but didn't work out that way. Dr. Johnson, here's a very common question. I think an important question. Is there a cost for the vaccine?
$1 million.
Is there a cost for the patient? Let's clarify that.
That's right.
It's probably a quadruple trillion-dollar cost, but how about for the patient? Is there a cost for it?
No, there isn't, fortunately. The vaccine should be provided to anyone who requests it. And so the vaccine should be is free. And if it is hospitals and certain facilities can bill private or government insurance for administering the vaccine, any cost that's for needles and the technique involved in administering the vaccine, but otherwise that it's a free vaccine. For those who are uninsured, there is also funding for that as well. The name escapes me right. The funding program escapes me right now, but there is options for that. So in times like this, it's the best thing to do. So yes, there should be no cost for the vaccine.
Right, and that's a great point. And I think, um, the decision makers and the powers that be and the folks that are higher pay grades than us, I think appropriately saw the fact that we can't let healthcare inequities or lack of healthcare coverage stand in the way of getting out of this. Dr. Gomez, what should I worry about when it comes, or should I worry about anything when it comes to getting the COVID vaccine? We talked a little bit about these episodes of anaphylaxis. When we do the Aggie math, we realize the incidence is actually pretty darn low. And again, much lower as compared to very common antibiotics we prescribe. Or is there anything we should be concerned about? It can't all be fairy tales and unicorns.
Yeah, the only thing that you should worry about is how fast you can get it. So as soon as it becomes available to anyone, they should definitely make their way to their pharmacist or to their doctor's office and get the vaccine. That's probably good advice for anyone, I think.
Okay. And I think that's a good segue. We have just two questions that have come in, and before we wrap up, I think this is a good, your intro there, your answer was, is it okay to switch vaccines and start over if a second dose of the original vaccine can't be obtained? I think the ideal answer is you wait for that, receiving that second dosage. It reminds me of the scene from Jerry Maguire, right? Show me the money. In this case, it's show me the vaccine. There are some asks of faith in this. Yes, we are administering X number of vaccines to a region, and trust us that others will follow. Hey, listen, any one of us watching tonight might have some reservations on how much do I trust that. I think what we can say, and I'd welcome Doctors Johnson or Gomez disagreeing with me, is we've not seen a slowdown in supply. We've seen a slow supply, but we haven't seen any decreases. So I think we should be okay in that regard. Dr. Gomez, any thoughts about that?
So the first thing that I would say is that there's probably no empirical evidence or studies that were done to address that directly because of the fact that Pfizer conducted their studies with their Pfizer vaccine. Moderna conducted their studies with the Moderna vaccine. And I would be very surprised, and I haven't heard of any studies where using both were conducted. So there's no way to really address that with any scientific evidence. But I agree with you in the sense that I think that what we're going to find is that there will be sufficient amount of the same vaccine that you started with to take the second dose. And that would be, I think, a good recommendation for anyone.
Last question, and I certainly don't know the answer to this. I'm gonna probably punt this one to Dr. Gomez or Dr. Johnson if either one of you know this. The person asking the question is a healthcare provider. She's a healthcare worker. She's pregnant. She's researching this, and she can't find any literature as to whether or not the messenger RNA or the COVID spike protein would cross the placenta. Do we know that?
That's a fantastic question. And to be honest, I don't know if pregnant women were in the cohort of patients that were studied when the vaccine was being studied in clinical trials. But what I will say, of course, is that the antibodies will cross the placenta. So whatever maternal antibodies are present, even if they're against the COVID or the SARS-CoV-2 virus, they will also protect the fetus because of the fact that antibodies will cross the placenta, whether or not the spike protein or the virus itself does. I honestly don't know.
Okay.
I agree, because I was looking into that as well. And Dr. Gomez is right. There doesn't seem to be a lot of data on that. The theory, though, is that it should be safe, but there really isn't any hard data to really to support that. But in theory, how the mechanism of action of the vaccine should make that not an issue. The only thing you would do is, as Dr. Gomez said, you would only be adding to protection of the fetus.
Right. We know that the American College of Obstetrics and Gynecology have in their position statement, and I'm paraphrasing, have stated being pregnant is not a contraindication to receiving the vaccine. So they sort of threaded the needle in providing that guidance. Well, listen, Dr. Johnson, Dr. Gomez, thank you so much for joining us tonight, providing some answers to many commonly asked questions. And thank you for those of you who have joined us on this Facebook discussion tonight. We hope that this provides you further information, further guidance, further clarity. We want to get through this, and it's going to take a collaborative effort. It's going to take maintenance of those 3 pandemic commandments. And I know we're getting tired of them, but we got to stay strong. There is a light at the end of the tunnel, but we also need to make sure that by our actions or inactions, we don't inadvertently turn that light into a freight train barreling down on us. So take care of each other, love each other. We're going to have your back. We're going to tell you when. I simply don't know, and when it's time to talk to your doctor. So everybody be safe, take care of each other, get that shot in the shoulder as soon as you can. Bye-bye now.